Hi everyone. In today's lecture video, I'm going to discuss WHO Consolidated Guidelines on Tuberculosis, Module 1, which is Prevention, and its tuberculosis preventive treatment. So basically it's gonna all about latent tuberculosis WHO guidelines. Let's begin and discuss important points in the guideline. So according to the WHO guidelines, what is latent TB? It is defined as a state of persistent immune response to a stimulation by Mycobacterium tuberculosis antigen with no evidence of clinically manifest active TB. So it is a state of immune response which is occurring because of stimulation by an organism, but not clinically manifesting a disease itself, which is an active TB. What were the objectives of the guidelines? So the main objectives were to reflect a new evidence on shorter rapamycin-containing preventive regimes from trials reported after 2018 edition of the guidelines, and to improve the clarity and global applicability of its recommendation. So instead of going to the introduction, I'm going to show you the recommendations itself, and we will discuss these recommendations one by one. So the first target of the recommendations were to identify a population for latent TB testing and TB preventive treatment. So whom we are targeting, to whom we are checking that these patients should get a testing or should get a preventive treatment. So according to the guidelines, the recommendation number 1 was adult and adolescents living with HIV who are unlikely to have active TB should receive TB preventive treatment as a part of a comprehensive package of HIV care. Treatment should also be given to those on antiretroviral treatment, to pregnant women, and to those who have previously been treated for TB, irrespective of the degree of immunosuppression, and even if latent TB testing is unavailable. I'm just reading all the recommendations right now because in the later half of the video, I'm going to discuss each and every recommendation with an evidence. So recommendation 2 was infants aged less than 12 months living with HIV who are in contact with a person with TB and who are unlikely to have active TB on an appropriate clinical evaluation according to a national guidelines should receive a TB preventive treatment. Number 3, children aged above 12 months living with HIV who are considered unlikely to have an active TB on an appropriate clinical evaluation or according to national guidelines should be offered TB preventive treatment as a part of a comprehensive package of HIV prevention and care if they live in a setting with a high TB transmission, regardless of a contact with a TB. Number 4, all children living with HIV who have successfully completed treatment for TB disease may receive TB preventive treatment. Second, household contacts, regardless of HIV status. So first, they were targeting people living with HIV, in which they have explained adult and adolescents, infants, children, and all children living with HIV. Now they are targeting household contacts regardless of an HIV status, in which they have characterized into 3 points. Number one was children of less than 5 years who are household contacts of people with bacteriologically confirmed pulmonary TB and who are found not to have active TB on an appropriate clinical evaluation or according to national guidelines should be given TB preventive treatment even if the latent TB testing is unavailable. So household contacts of a confirmed TB patients less than 5 years of age, they should get a treatment, preventive treatment. Children aged more than or equal to 5 years, adolescents and adults who are household contacts of people with bacteriologically confirmed pulmonary TB who are found not to have active TB by an appropriate clinical evaluation or according to national guidelines may be given TB preventive treatment. So the two sentences should be given and may be given. Next point, in selected high-risk household contacts of a patient with multi-drug resistant tuberculosis, preventive treatment may be considered based on individualized risk assessment and a sound clinical justification, like an expert guide. So the other group, they targeted other people at risk, people who are initiating anti-TNF treatment or receiving dialysis or preparing for an organ or hematological transplant or who have silicosis should be systematically tested and treated for latent TB. So they clearly give a very good guidelines whom we are testing. Patients who are about to initiate an anti-TNF treatment or receiving dialysis or preparing for an organ or hematological transplant or who have silicosis. Systemic latent TB testing and treatment may be considered for prisoners, health workers, immigrants from countries with a high TB burden, homeless people, and people who use drugs. So this can be considered. We can consider for testing. But in these patients, we should be systemically tested and treated. In these people, we can consider like prisoners, the doctors or the healthcare workers, immigrant from countries with a high TB burden, homeless people, or people who use drugs. Next point, systemic latent TB testing and treatment is not recommended for people with diabetes, people who engage in harmful use of alcohol, tobacco smokers, and underweight people unless they also belong to other risk group included in the above recommendations. So it's very clear, not recommended in diabetes, people who engage in harmful use of alcohol, tobacco smokers, or if they are underweight. It is not recommended. Moving on. Algorithm to rule out active TB. Adults and adolescents living with HIV should be screened for TB according to a clinical algorithm. We will discuss this algorithm in the later half of the video. Those who do not report any of the symptoms of current cough, fever, weight loss, or night sweats are unlikely to have active TB and should be offered a preventive treatment regardless of their ART status. So what could be the sign and symptoms of an active TB should be considered? Current cough, fever, weight loss, night sweats. Next point. Adults and adolescents living with HIV who are screened for TB according to a clinical algorithm and who report any of the symptoms of current cough, fever, weight loss, or night sweats may have active TB and should be evaluated for TB and other disease and offered a preventive treatment if active TB is excluded. Chest radiography may be offered to all people living with HIV on antiretroviral treatment and preventive treatment given to those with no abnormal radiographic findings. So we have to offer a chest radiograph before before declaring patient that he has no active TB. Later point, infants and children living with HIV who have a poor weight gain, fever or current cough, or who have a history of a contact with a person with the TB should be evaluated for TB and other disease that cause such symptoms. If TB disease is excluded after an appropriate clinical evaluation or according to national guidelines, these children should be offered a TB preventive treatment regardless of their age. So in children, you have to consider a poor weight gain as well. Recommendation number 15, the absence of any symptoms of TB and the absence of abnormal chest radiographic findings may be used to rule out active TB disease among HIV negative household contacts age of more than or equal to 5 years and other risk group before preventive treatment. 1.3 is testing for latent TB. Either a tubercular skin test or IGRA, that is an interferon gamma release assay, may be used to test for latent TB. Either of the tests can be used. 1.4 TB preventive treatment options. Recommendation 17. The following options are recommended for the treatment of latent TB regardless of an HIV status. 6 or 9 months of daily isoniazid or 3 months regime of weekly rifampicin plus isoniazid or a 3 month regime of daily isoniazid plus rifampicin. A 1 month regime of daily rifampicin and plus isoniazid or 4 months of daily rifampicin alone may also be offered as an alternative. There is a very good table by the WHO guidelines that we will discuss in the later half of the video. Recommendation 18. In settings with high TB transmission, adults and adolescents living with HIV who have unknown or a positive latent TB test and are unlikely to have active TB disease should receive at least 36 months of daily isoniazid preventive treatment IPT. Daily IPT for 36 months should be given whether or not the person is on ART and irrespective of the degree of immunosuppression, history of a previous TB treatment, and pregnancy in the settings considered to have a high TB transmission as defined by national authorities. So these were the main guidelines. They are 18 in number and they are characterized as first category is the people living with HIV, what we should be doing with those patients. Then and they describe according to the age what to do in adult and adolescents, infants less than 12 months, children above 12 months, and all children who have successfully treated for the TB may receive a TB preventive treatment. Then second half they included household contacts regardless of an HIV status, in which they very beautifully define as children less than 5 years of age, children above 5 years, adults and adolescents. And the later half, the third half, they included the people at risk. What is the list of a patient should be considered, and should be and should may be considered. So they have given both the list, and the later half they have explained an algorithm to rule out an active TB disease, then how to test it and what treatment to begin with. So the main changes to the guidelines in the current update as compared to the 2018 are these. The text of 5 recommendations was added to reflect their applicability regardless of the TB burden in the country or setting. An additional commentary added to highlight the implications for their use in settings that differ in TB burden and resources. Recommendations and accompanying consideration for TB preventive treatment in contacts and in clinical occupational risk group have been slightly reworded to improve any undue stress on their application to HIV-negative individuals only. 3 previous recommendations on the systemic latent TB testing and TB preventive treatment in low-burden settings and in people living with HIV and household contacts under 5 years of age before the start of treatment are now presented amongst the implementation consideration. One recommendation has been updated to include both 1 month of isoniazid and rifampicin and 4 months of rifampicin as an option for TB preventive treatment in all settings. 3 previous recommendations on the use of 6 months of isoniazid or 3 months of isoniazid rifampicin in people under 15 years of age and 3 months of isoniazid and rifampicin in high TB prevalence setting no longer feature by themselves, as these regimes options are now covered by one recommendation that lists all acceptable TB preventive treatment options in any setting. The variable duration of 3 to 4 months of daily rifampicin and 3 to 4 months of daily rifampicin plus isoniazid in the previous recommendations have been simplified to 4 and 3 months respectively, being the length of time for which these treatments are usually given. A single algorithm replaces the 4 in 2018 guidance, harmonizing the key decision points for latent TB testing and TB preventive treatment of individuals at risk. The content of the guidelines has been updated, citing recent references and latest available evidence, such as one use of rifampicin with dolutegravir and isoniazid preventive treatment in pregnant women with HIV. The research gaps have been updated to reflect the latest evidence reviewed. So these were actually some updates from the last 2018 guidelines. Now we will discuss each recommendation in detail. So the recommendation 1 was identification of a population for testing of latent tuberculosis and TB preventive treatment. And this was all about HIV, people living with HIV. Adults and adolescents living with HIV who are unlikely to have active TB. So first of all, you have to rule out there is no active TB. Should receive a TB preventive treatment as a part of a comprehensive package of HIV care. You are diagnosing, you are seeing any patient or you are suspecting any patient with an HIV, you should keep in mind about tuberculosis as well. Treatment should be given to those on antiretroviral treatment, to pregnant women and to those who have previously been treated for TB. Despite that patient is getting treatment for HIV, despite that patient is pregnant, despite he had previously been treated for TB, you have to think about a latent TB disease in a patient who have diagnosed with HIV now. Irrespective of the degree of immunosuppression and even if latent TB testing is unavailable, this is a very strong recommendation, high certainty in the estimates of effect and very strong recommendation. So, HIV patient adult or adolescents living with HIV, even in those countries in which testing for the latent TB is not easily available, you can offer patient treatment. What is the justification of the evidence? Global data indicate that people living with HIV are about 20 times more likely to develop active TB than those without HIV infection. So they are 20 times more likely to develop an active TB. The recommendations for TB preventive treatment for all people living with HIV was first published by WHO in 2011. A systemic review of 12 randomized controlled trials found that preventive treatment reduced the overall risk for TB by 33%, which is a huge number. A systemic review of studies conducted before ART became available showed the value of providing preventive treatment immediately after successful completion of TB treatment among people living with HIV in countries with a TB incidence of more than 100 per 100,000 population. Therefore, preventive treatment is recommended for people who are previously treated for TB. So this is the answer why we are offering to the patients who actually have already been treated. For setting with high TB transmission, however, daily IPT for 36 months or longer is recommended conditionally. So we will discuss this in the later half that IPT for 36 months is a conditional thing. Pregnancy should not disqualify women living with HIV from receiving preventive treatment with medicines commonly used to treat active TB that are generally considered safe for use in pregnancy, such as isoniazid and rifampicin. So, as a physician, if we are about to diagnose somebody with HIV, we have to keep in mind about the TB as well. Next point. So, this is about infants, age of less than 12 months living with HIV or in contact with a person with TB and who are unlikely to have active TB on appropriate clinical evaluation or according to national guidelines should receive TB preventive treatment, and this is also a strong recommendation. So infant of less than 12 months should also receive TB preventive treatment. Children of more than or equal to 12 months living with HIV who are considered unlikely to have an active TB on an appropriate clinical evaluation or according to national TB guidelines should be offered TB preventive treatment as a part of a comprehensive package of HIV preventive and care if they live in a setting with high TB transmission regardless of the contact with TB. This is also a strong recommendation. All children living with HIV who have successfully completed a treatment for TB may receive TB preventive treatment. So in adult category, if they have completed a treatment for TB disease, they should get a treatment. They should be considered for the treatment. But in children's category, it's may receive. They may receive. It depends on the physician and the current status of a patient. Justification for this recommendation: WHO published guidelines on tuberculosis preventive treatment in 2011. Two South African studies found that giving isoniazid to HIV positive children for 6 months resulted in significant drop in mortality and TB protection. Infants who had no known exposure to active TB and those who were started on antiretroviral therapy right away, on the other hand, did not show any benefit. Despite scant evidence, GDG advised a preventive treatment for kids under 12 months old who lack clinical signs of active TB infection. For kids with HIV who are at risk of reinfection, GDG also suggested a prophylactic treatment. All children with HIV who have undergone successful TB treatment should receive a preventive care even if there is no evidence to support this. So we have no very strong evidence, but still WHO recommended. Now coming to the household context. Children of less than, so they've characterized this into two: children of less than 5 years and more than 5 years and adults. Children of less than 5 years who are household contact of people with bacteriologically confirmed pulmonary TB and they have not found any active TB on appropriate clinical evaluation or according to national guidelines should be given TB preventive treatment even if latent TB testing is unavailable. So if any of the individual diagnosed with a TB, according to WHO guidelines, any individual diagnosed with TB, we have to ask if he is in contact with anybody whose age is less than 5 years. So we should offer them TB preventive treatment, regardless if the TB testing, latent TB testing latent TB testing is not available there, and it's a very strong recommendation, high certainty. What happened with the children of more than 5 years of age, adolescents and adults who are household contact of people with bacteriologically confirmed pulmonary TB who are found not to have active TB by an appropriate clinical evaluation or according to national guidelines may be given TB preventive treatment. So if the age is less than 5, you should be given a preventive treatment. If the age is more than 5 years or if it's adult or adolescents, you may consider. You can offer to the patient, but that is conditional. Justification for this recommendation. WHO issued two sets of recommendations in 2015 and 2018 backed by a systemic reviews and evidence. A systemic review in 2018 focused on household contact in countries with a high tuberculosis incidence rate, aiming to determine latent TB prevalence, progression to active tuberculosis, and cumulative active TB prevalence among those contacts. Originally, the recommendations primarily applied to HIV-negative child contacts, but later updates extended them to include children living with HIV who are household contact of TB patients. Latent TB prevalence was higher in older individuals more than 15 years and adults compared to children under 5 years who had the highest risk of advancing to active TB. The risk of advancing to active TB was lower in children between 5 to 15 years and those over 15 years compared to children under 5 years. That's why they are recommending it. However, all household contacts, irrespective of the age or latent TB status, still face a significantly increased risk of active TB compared to general population. So if one patient diagnosed with a TB, their household contacts are at increased risk, especially if the age is less than 5 years. This should be given a preventive treatment. If it's more than 5 years, maybe. But they are at increased risk of active TB as compared to the general population. Moving on to the next recommendation. Context of a multi-drug resistant tuberculosis patient. So they have now added MDR context as well. In selected high-risk household contacts of patients with multi-drug resistant tuberculosis, preventive treatment may be considered based on individualized risk assessment and a sound clinical justification. Basically, it is a conditional recommendation, so a physician can reassess the patient's condition, the contact condition, any risk factors. All the conditions should be checked by a physician and then can decide that patient could have considered for a preventive treatment. Justification and evidence. The recommendation was introduced in 2018 guidelines. A systemic review was conducted for 2015 guidelines to assess a preventive treatment effectiveness for contact of multi-drug resistant tuberculosis patient. The updated review included 10 studies, 6 new and 4 from previous review, allowing for comparison between those receiving preventive MDR-TB treatment and those who did not. Quality of evidence was based on 4 studies. One study used isoniazid monotherapy and 5 had fewer than 20 participants completing a preventive TB treatment. The guideline development group found a potential benefits of targeted preventive treatment for MDR-TB context with uncertainty due to lack of randomized controlled trial evidence. Guideline development group emphasized a thorough risk assessment considering of factors like exposure, intensity, source certainty, drug resistant patterns, and adverse reaction, and on the basis of these can decide should a person be treated for a preventive TB or not. Moving on, the next recommendation, other people at risk. So people who are initiating an anti-TNF treatment, receiving dialysis, are preparing for an organ or hematological transplant, or who have silicosis should be systematically tested and treated for latent TB. Tested and treated for latent TB. And this is a strong recommendation. So if any of the patient is about to be start on anti-TNF treatment, or patient is undergoing dialysis, or your patient is about to go for organ or hematological transplant, or have silicosis, you should offer a testing like a tuberculosis test or IGRA, and on the basis can be treated for latent TB. So systemic latent TB testing and treatment may be considered for prisoners, health workers, immigrants from countries with high TB burden, homeless people, and people who use drugs. This is conditional. So they may be considered, but they should be of for anti-TNF treatment, dialysis, organ transplant or hematological transplant, silicosis, may be considered prisoners, healthcare workers, immigrants from a high TB burden country, homeless people, or people who use drugs. They may be considered. Next is systemic latent TB testing and treatment is not recommended. Not recommended for people with diabetes, people who engage in harmful use of alcohol, tobacco smoker, and underweight people unless they also belong to other risk group. So according to WHO latent TB guideline, diabetes people, diabetics, people who engage in harmful use of alcohol, tobacco smokers, and underweight, they don't need to be testify for latent TB. Their evidence is WHO introduced these recommendations in 2015. The GTG examined evidence from systemic reviews conducted from previous latent TB guidelines. The evidence show increased latent TB prevalence, progression risk to active TB, and active TB incidence in 15 risk groups, including healthcare workers, people living with HIV, immigrants from high TB burden countries. Among these, 4 groups had a notably higher risk of progressing from latent TB to active TB, which were people living with HIV, TB contacts, dialysis patients, underweight individuals. Patients initiating anti-TNF treatment, those on dialysis, transplant candidates, and patients with silicosis are identified as a priority group for latent TB testing and treatment. Even with limited evidence, and strong recommendations were made for them. For healthcare workers, students, and immigrants from high TB burden countries, prisoners, homeless individuals, and people who use drugs, benefits to latent TB testing and treatment will not always outweigh the potential harm. Local epidemiology, healthcare capacity, equity, and health priorities should guide a decision. Recent immigrants, especially from higher TB burden countries, may be prioritized for latent TB testing and treatment, particularly within the first few years after entry. Despite evidence of increased latent TB and active TB in individuals with diabetes, those engaging in harmful alcohol use, tobacco smokers, and underweight individuals, The GTG noted a lack of clinical trial data on benefits and harms of systemic latent TB testing and treatment for these groups. Moving on to other recommendations, ruling out active TB disease. Adult and adolescents living with HIV should be screened for TB according to the clinical algorithm. So now how to rule out active TB? First, you suspected in the individuals who are at very high risk, like people living with HIV, household contacts. Then second, you did in high risk groups like TNF, a patient was about to start on anti-TNF therapy, dialysis, silicosis, or the other priority risk for consideration. Once you have suspected, now the second step is to rule out active TB. Very important. Adult and adolescents living with HIV should be screened for TB according to the clinical algorithm. Those who do not report any of the symptoms of current cough, fever, weight loss, or night sweats are unlikely to have an active TB and should be offered a preventive treatment regardless of their antiretroviral therapy status. This is a strong recommendation. Adult and adolescents living with HIV are screened for TB according to a clinical algorithm and who report any of the symptoms of current cough, fever, weight loss, or night sweats may have active TB and should be evaluated for TB and other diseases and offered a preventive treatment if active TB is excluded. So if any of the patients have these symptoms, then you should have evaluated for further testing, and if once it's being ruled out, then you can offer a preventive treatment. Chest radiograph may be offered to people living with HIV on ART, and preventive treatment be given to those with no abnormal radiographic finding. So you have to offer the chest X-ray before starting a treatment so that we can rule out if there is any abnormal radiographic finding. So it may be offered. Infants and children living with HIV who have a poor weight gain, fever or current cough, or who have a history of contact with a person with TB should be evaluated for TB and other diseases that cause such symptoms. If TB disease is excluded after an appropriate clinical evaluation or according to national guidelines, these children should be offered a TB preventive treatment regardless of their age. Evidence. These recommendations encompasses 3 components, including 2 initially published in 2015 and updated in 2018, and a third introduced in 2018 building upon a 2011 guidelines position. 2011 guidelines recommended a symptom screening rule for adults and adolescents featuring current cough, weight loss, night sweats, and fever with a sensitivity and specificity and a negative predictive value statistics. Most people living with HIV in the review were not on the ART. In 2018 update, a systemic review compared with a performance of 4 symptom screening in people living with HIV on and off ART, reporting sensitivity and specificity values. Adding abnormal chest radiographic finding had marginal benefits but could increase a false positives. In people living with HIV on ART, the negative predictive value of the symptoms in screening rule was high. At a TB prevalence, chest radiography addition slightly improved it. Infants and children living with HIV had a screening rule, a 2018 study showing sensitivity and specificity values. Recommendations were made for adult, adolescents, and children living with HIV, advocating the use of 4 symptom screen for ruling out active TB, regardless of an ART use. And now you have to write down in comment what were these symptoms. Confirmation of latent TB before preventive treatment initiation is encouraged, with caution regarding the addition of chest radiograph. Pregnant women may benefit with proper radiation precautions. Infants and and children living with HIV should undergo a routine TB screening. Symptom-based screening is acceptable and feasible, with TB preventive treatment offered to most, except infants under 12 months without TB contact history. Further TB testing guidance for those with suggestive clinical features was noted. Now, household contacts age above 5 years in other risk group. The absence of any symptom of TB and the absence of abnormal chest radiographic findings may be used to rule out active TB disease among HIV-negative household contacts age more than or equal to 5 years in other risk group before preventive treatment. Its justification: this recommendation, introduced in 2018 guidelines, is conditional and based on low quality evidence. The recommendation stems from a systemic review conducted for 2015 guidelines assessing the sensitivity and specificity of screening for active TB in HIV-negative individuals and those with unknown HIV status. A model comparison highlighted that a combination of any chest radiograph and abnormality and symptoms suggestive of TB provide the highest sensitivity and a negative predictive value of 100% for ruling out TB. An updated review before 2018 guidelines focusing on household contacts of age more than 5 years of pulmonary TB patients in high TB burden countries reported a sensitivity of 94 and a specificity of 86% for any chest X-ray abnormality. In a hypothetical population of 10,000 HIV-negative individuals with a 2% TB prevalence, using any TB symptoms alone and misclassify as a TB patient, while any abnormal chest radiograph identifies them incorrectly, combining symptom and chest radiograph prevents any misconception. At a 2% TB prevalence, using any TB symptoms alone requiring a TB investigation for 6 extra non-TB patients for such TB cases identified. Using any abnormal chest radiography findings require investigations for 7 extra non-TB patients per TB case identified. Combining symptoms and chest radiography increased the number to 15 extra non-TB patients per TB case identified. In short, if there is no symptoms and you have done the chest radiography, active TB has been ruled out, you can offer them a treatment. This is a very good algorithm for latent TB testing and TB preventive treatment in individuals at risk. At this point, I do ask a favor from you. If you guys can subscribe to this channel. Thank you so much. Back to the video. So, HIV positive patients, any symptom of current cough or fever or weight loss or night sweats? No. Preventive treatment contraindicated? No. Give up preventive treatment. HIV positive, no active TB, no contraindication, give treatment. What are the contraindications? Acute or chronic hepatitis, peripheral neuropathy, if isoniazid is used, regular and heavy alcohol consumption, pregnancy or a previous history of latent TB are not contraindication. HIV positive patient, any symptom of current cough or fever or weight loss or night sweats? Yes, investigate for active TB. No active TB? Check for contraindication. Contraindication present, defer a preventive treatment. In both the cases, follow for active TB as necessary even for patients who have completed a preventive treatment. If there is no contraindication, then simple you can give a preventive treatment. Second group, household contacts. Household contacts, symptomatic? Yes. Investigate for active TB? No. Check for an age, if less than 5 years of age. Check for contraindication, no contraindication. Give a preventive treatment. There is no need to do a testing. Household contacts, 5 years or above age, testing should be done. TST or IGRA. Positive or unavailable. If it's positive or unavailable, you can offer them a preventive treatment after checking contraindication. And check for a chest x-ray as well if it's normal or abnormal and can act accordingly. Other risk groups, as we have defined the other risk groups already. And for a revision purpose, you can write down in a comment section as well. These were silicosis, dialysis, anti-TNF agent treatment, preparation for transplantation. You can go for testing, and according to the test, can act. So let's talk about the testing. Either a tuberculin skin test or interferon gamma release assay can be used to test for latent TB. Strong recommendation. Two commercially available IGRAs are quantiferon TB, gold in tube and T-spot. Testing is recommended for identifying incident active TB in countries with a TB incidence of more than 100 per 100,000 population. 5 prospective cohort studies compared the predictive performance of IGRA and TST for identifying incidence active TB. 2 tests were equivalent options with relatively similar advantages and disadvantages. GTG recommends the urgent resolution of global shortage for TST and more investment in research and novel tests for latent TB with a better predictive value. Latent TB testing by TST or IGRA should not be a prerequisite to start a TB preventive treatment in people living with HIV and household contacts of less than 5 years, particularly in settings with high TB incidence, given that benefit outweigh the risk. This is very important. So coming to the interesting part, what is the tuberculosis preventive treatment options available? Instead of reading this recommendation, I'll go directly to this table, which is very good, in which they have given dosage as well. So one option is 6 or 9 months of daily isoniazid monotherapy. Age 10 years and older 5 milligrams per kg per day. Age less than 10 years 10 milligrams per kg per day. 4 months of daily rifampicin. Age 10 years and older 10 milligrams. Age less than 10 years 15 milligrams per kg. 3 months of daily rifampicin plus isoniazid. 3 months of rifapentin plus isoniazid weekly. 1 month of rifapentin and isoniazid daily. 6 months of levofloxacin daily, that is a preventive treatment for MDR-TB. So is it 1 month? Is it 3 months? In 3 months, we have two options. Is it 4 months or 6 or 9 months? In 1 month regime, you can offer HP, which is daily, isoniazid and rifampicin, age more than or equal to 13 years, regardless of weight bent. Isoniazid is 300 and rifampicin is 600 milligrams per day, and total of 28 doses are about to give. In 3 months, we have two options, either isoniazid and rifampicin 3 months, which is daily, or 3 months of HP, which is weekly. Four months is single rifampicin, or 6 or 9 months of single isoniazid. Moving on to its evidence. The revised recommendations make all latent TB options applicable to all settings. However, showed that benefits of isoniazid increase progressively when it is given for up to 9 to 10 months and stabilizes thereafter. For this reason, 9 months is retained as an alternative regime to 6 months in the recommended TB preventive treatment options. Authors also reported a lower risk of adverse events and a higher adherence rate among children to given daily rifampicin plus isoniazid. 3 to 4 months had a lower risk for hepatotoxicity than those treated with isoniazid monotherapy. Treatment options for people living with HIV. People living with HIV can choose from various treatment options. Conditional recommendations for daily isoniazid monotherapy. The recommendations for giving at least 36 months of daily isoniazid monotherapy to people living with HIV in high TB transmission settings is conditional. This is based on evidence that long-term IPT adds significant benefits to ART. Testing for latent TB in people living with HIV. While testing for latent TB is not required for TB preventive treatment in people living with HIV, if it should be encouraged. Individuals who test positive for TST have a greater benefit from TB preventive treatment. So they are not recommending it to test, but if you're doing a test and it's coming out positive, then it's a greater benefit for a patient. People living with HIV with a negative TST should not receive 36 months of daily IPT. So this is also a very important point, and highlight the importance of doing a testing in people living with HIV, so that if it's negative, then 36 months, they are not applicable for 36 months of daily IPT. Strong recommendations for 3 months of HR in adults and children. GTG unanimously agreed with 3HR rifampicin and isoniazid is highly beneficial for infants and children under 15 years due to its safety, higher completion rate, and availability of child-friendly formulations. However, data for children under 2 years are limited. So 3HP is only recommended for children aged 2 years and older, while 1HP is recommended for those aged 13 years and older. Pregnancy. Evidence on pregnancy in IPT. A systemic review in 2019 assessed evidence related to adverse pregnancy outcome associated with IPT, isoniazid preventive therapy. In this review included one randomized controlled trial and 3 observational studies focusing on women with HIV. RCT findings. The RCT showed a higher risk of adverse pregnancy outcome in women who initiated IPT during pregnancy with a mental Ansel odds ratio of 1.51. Observational studies, in contrast, all three observational studies reported an overall odds ratio of less than 1, suggesting that the opposite trend. A meta-analysis of two observational studies with adjusted estimates indicated a lower risk for composite adverse pregnancy outcomes with odds ratio of 0.40. Individual adverse outcomes. The observational studies did not replicate the association with IPT reported by randomized controlled trial for individual adverse outcomes such as fetal neonatal death, prematurity, low birth weight, and the congenital anomaly. Maternal hepatotoxicity and other risks. One of the 4 studies reported statistically significant risk for maternal hepatotoxicity, grade 3 or 4 events or death. The GDC concluded that there were insufficient grounds to change the previous guidance or to develop a separate recommendations for the use of IPT in pregnant women with HIV. They believe that deferring IPT to postpartum period would deprive women of its preventive effect at the time when they are more vulnerable to TB. Proper care during antenatal and postnatal periods, including delivery, may reduce the risk of adverse pregnancy outcome. While baseline liver function tests when giving IPT during pregnancy are strongly encouraged and feasible, routine liver function testing during pregnancy is not indicated unless another risk factor for liver toxicity are present. Vitamin B6 supplementation should be considered. GDG recognized the need for future research in areas such as pharmacokinetics and pharmacovigilance of IPT and more other preventive treatment regimes. Rifampicin is generally considered safe in pregnancy, but there are limited data on pharmacokinetics and safety of rifampicin in pregnancy, so its use in pregnancy should await more data to ensure appropriate dosing and preliminary safety information. So this slide is all about monitoring. Monitoring and evaluating of latent TB care, especially among child contacts with people living with HIV, is crucial. Courage of contact investigation and TB preventive treatment for those groups is a key indicator for tracking and implementation of anti-TB strategy. National TB and HIV programs report data annually to WHO and UNAIDS regarding progress in latent TB care in target populations. So monitoring and evaluation system should align with national patient monitoring and surveillance system. Routine monitoring. Individuals on TB preventive treatment should be monitored routinely at monthly encounters with healthcare providers. Providers should explain the disease process, treatment rationale, and the importance of completion of treatment. Patients should be advised to contact their healthcare provider if they experience symptoms such as anorexia, nausea, vomiting, abdominal discomfort, fatigue, dark color urine, pale stool, jaundice, confusion, or drowsiness. This is a very important point. So whenever you are starting any of the patient on a TB preventive treatment, should have guide them if they are experiencing any of these symptoms, including anorexia, nausea, vomiting, abdominal discomfort, fatigue, dark colored urine, pale stools, jaundice, confusion, or drowsiness. They should stop the treatment immediately and they report to the healthcare worker. Baseline liver function testing. Baseline liver function testing is strongly encouraged, particularly for individuals with a specific risk like a history of liver disease, harmful alcohol use, chronic liver disease, HIV infection, age over 35, pregnancy, postpartum within 3 months. Abnormal baseline test results should prompt regular testing and subsequent visits. Anti-TB drug resistance. There is no significant association between anti-TB drug resistance and use of isoniazid or rifamycin for latent TB treatment. However, active TB must be excluded before initiating TB preventive treatment, and surveillance for anti-TB drug resistance may need strengthening in countries scaling up multi-drug resistant. Monitoring adherence and ensuring treatment completion are vital for clinical benefits. Electronic application for mobile phones have been created by WHO to guide it. Active TB monitoring, collecting information about active TB occurrence in the individuals who have received TB preventive treatment is important. This can be done through patient inquiries or cross-linking registers. MDR TB preventive treatment monitoring for adverse events and adherence to treatment is crucial in individuals on MD TB preventive treatment. This type of adherence reaction depends on medicine's use, and monitoring should follow the WHO framework for managing the safety of TB medicines. Close monitoring for active TB, strict clinical observation, and close monitoring for active TB disease are required for at least 2 years. After MDR TB exposure, regardless of whether a preventive treatment was given or not, and consideration should be given to interaction with ART. And this is the end of video. I hope I have helped you understanding the latent TB WHO guidelines. Thank you.